maybe I'll do another case that they didn't have. Okay. Now, what I'm going to do is we're just going to go back with the hypertensive stuff. Usually I ask them the questions, but I'm just going to bring you up to date with it. So, this is the thing. When we're treating our patients, when we're treating them with hypertension, we know that the studies, from the heart failure studies, and the major one that we did was the VF study, the VF1 study. So the patients with class 3 and 4 heart failure that were hypertensive, okay, half of them got mini-Pres, or Prazosin. Half of them got the combination of isosorbide and hydralazine, okay? We had to stop the study, because even though the drop in blood pressure was the same, the mortality rate was higher in the mini-Pres group. Okay. Did I go over this study with you guys? Yeah. The VF1 study?
VF1
Okay. All right then. So why? So what? So since we had the same drop in blood pressure, what were we really treating? Because we're not really treating the number, right?
Yeah.
Right. So what are we really treating?
Endothelial dysfunction.
Right. Endothelial dysfunction. And why did the hydralazine isosorbide group treat the endothelial dysfunction? What was it doing to make the endothelial function better?
Nitric oxide.
Increased nitric oxide levels. Okay. So we know now that all blood pressure medicines are equal. That's why it's so important with what we start with. Okay. And then, so the two major systems that work on endothelial dysfunction is what? You mentioned the nitric oxide level. What's the other major system?
Calcium.
It's nitric oxide and one is nitrogen. I know the nitric oxide.
Think about what do we usually treat with?
Alpha blockers.
No, it's not.
Renin angiotensin system.
Yeah.
There you go.
Angiotensin system.
Okay. Because both of those feed into endothelial dysfunction. Which one is the most dominant system?
Renin angiotensin
Okay.
system.
And why do you say that?
Why it is more?
Why do you say that that's the dominant system?
I think
I can say I'm white, right? But
you can.
after me, I have a reason to back it up, right? Okay. So why is it the dominant system?
It has many different parts to control blood pressure.
Okay. Dad, what else?
Because
Hey, how you doing? How are you? I saw you next door.
You were in line. You were in line when I was coming out the door.
At Walmart?
it's more dominant issue.
At Walmart, right? Yeah. You were in line when I was coming out the door.
Oh.
Okay, that's why you were there. Okay, so why? Come on, guys, you're making me look
No.
Where do we get all that? I mean, why did you say from our dominant system? I agree with you. Why did you say that? I mean, did you just guess? Did you just
No.
some ghost whispered in your ear or what?
Maybe I have read it somewhere.
You probably did. So why do you say that's the dominant system? We were just talking about hypertension and endothelial dysfunction in the dominant system. And they told me that the dominant system was the nitric oxide system. So why did they tell me that? The angiotensin, the RAS system. So why did they tell me that that was the most dominant system for hypertension? Really, for hypertension, CHF, peripheral vascular disease, and all of them, because it's all the same.
Even the dominant system.
Why the renin angiotensin system is the dominant system over the nitric oxide?
Or the next for controlling what?
For treating endothelial dysfunction.
Because the any change in blood pressure, that is going to change the blood supply to the kidney. And kidney is the most, 25% of the blood supply is to the kidney. So any change in blood flow to the kidney stimulates.
No changing the blood flow with the hydralazine and
Maybe in some
isosorbide.
study it has been found out.
We have to study that.
Yeah, some study. So, because you have to have data on what you're talking about, right? Okay, that was the VHAV2 study. That's when we did a direct comparison with isosorbide, hydralazine, isosorbide. You have to have both.
Yeah.
Hydralazine by itself, nor isosorbide by itself. Neither one of those increase survival. Okay? And hypertension or congestive heart failure. So you have to have the combination of both to increase nitric oxide levels, okay? And that was from the VF1 study, okay? And then we had the consensus study. That was when the ACE inhibitors came out. But really, the first study that really came out was the ERIE study, the ramipril. But since the consensus study was the bigger study, that became the landmark study, okay? And what they did, they looked at those patients with class 3 and 4 heart failure who had hypertension and compared it to the standard of care. And in that group, they got the RAS blocker, survival was higher. You started seeing a split, really, after about 5 days, okay? So now, the next study was like, okay, which one is better? Is it better with the ACE inhibitors, or is it better with the direct vasodilator or nitric oxide inhibitor? Nitric oxide producers. You gotta remember, at the time that we did the studies, we just know that they increased survival. We didn't know exactly why. Now, knowing everything, we can go back and apply the physiology, right? Okay. I mean, we knew that the RAS blockers, we knew that the ACE inhibitors was a RAS blocker, but we didn't know exactly what the combination of isosorbide and hydrolysine was doing. Now we know that they increased nitric oxide. So then the next thing that came out was the VHF2 study, and that compared enalapril versus the combination of isosorbide and hydrolysine in patients with class 3 and 4 heart failure. Now, we already know that the isosorbide hydrolysine combination increased survival, right, compared to standard of care. And we already know that the enalapril increased survival. So this is like taking Boris, which is the single best answer, right? Because we know both of them increase survival. Now we want to see which one increased survival more. And in the consensus study, in the VF2 study, it showed that the RAS system, blocking the RAS system, was more important than producing nitric oxide because the enalapril increased survival compared to the combination. And we started seeing that separation even after a week, okay? So now we know that all blood pressure medicines are equal. And in treating hypertension, that's why we always start with the RAS blocker. Doesn't matter if they're pre-existing illnesses or anything, we start with the RAS blocker because that's the major pathophysiology, okay? That's why the step cure approach to treating hypertension is obsolete. Okay, it's obsolete. It's done. It's over. Yes, sir. Yeah. So you know, and that's why we don't start with the calcium channel blocker. That's why we don't start with the diuretic. Right. Because if we start with the calcium channel blocker or start with the diuretic or anything else, we're gonna get a drop in the blood pressure, right? It's gonna increase the baroreceptors right. Then we're gonna increase epinephrine, norepinephrine, and we're gonna stimulate angiotensin 2 through there. Okay? Right. So and that's what's supposed to happen. But it's what we call an inappropriate appropriate response. It's appropriate because that's what's supposed to happen. It's inappropriate because we have the damaged system, okay? And that's what those medications you reach a point of diminishing return. So it's real important that we start with the right medicine if we want to increase survival. Because we already know we can bring the blood pressure down and the patients don't live longer, right? And that's not what we want because we're not treating the number, okay? And in doing that, now what we have to do is change our definition of hypertension. Because we're not treating the number, okay, of hypertension. If we're not treating the number, then hypertension can't be that 140/90, right? It has to be something else, okay? And we're going to work our way through that, okay? Now we're going to jump ahead to something else. We had a study that's called the trophy study, okay? And what they did is they looked at patients that were pre-hypertensive. Blood pressure is 135/85, so they're not even hypertensive yet by our definition, right? They gave those patients irbesartan. They gave them an R. They had a 10-millimeter drop in blood pressure, okay? Now, if I gave you an R, I gave you an R, I gave you an R, and you an R, unless your system is messed up, nothing should happen. Blood pressure should be the same. So in these patients who were pre-hypertensive, to have a drop of 10 millimeters of mercury in their blood pressure by giving them an R, we already have a system that's damaged. So if the system is damaged, that's not a pre-disease state. That's a disease state already, okay? And that's the RAS system, okay? So, and that's why it was so important. Now, they didn't know why it happened at that time. So, now that leads us to why, in our practice, our cutoff for hypertension is 130/80, okay? Because we already know that at 135/85, we have an abnormal system. Okay, with that 140/90 can't be an acceptable cutoff, right? We're gonna leave it as an acceptable legal cutoff. We don't want people getting sued because they can't get the blood pressure to 130/80. But we know as clinicians that our cutoff of 140/90 is not acceptable. Now, if we had the ideal blood pressure of 115/75, okay? That's the ideal. That's what we want to get everybody, if we could do it. We'll apply the Coleman rule, if I call it, okay? We had 20/10,
It
okay?
was actually written in some Scadsem book, I think, pharmacology. Any increase in blood pressure, 1 millimeter increase in the blood pressure from 115 millimeter of systolic. That means if you have 115/75 millimeter of mercury, the blood pressure, and any increase of 1 millimeter increase the chance of risk of a stroke by 10%.
Yeah, essential.
So it's better to start antihypertensive drug before it reaches 130 or 120.
Well, you know what? We're not going to do that though because
And I
you run
remember I studied
into problems with the medications, and you do get that drop. But once we get them down, once we get them down under 120, we're safe. You know, with that. So, and 130, really, we're safe according to the trophy study. The only thing I wanted to point out is that the 140/90 isn't really unacceptable. It's a good trade-off, but it's not the optimal cutoff. And the reason for that, if we have a person with the blood pressure, like I was saying, 115/75, that's the idea. Okay? We are 20/10, okay, the Coleman rule. We have a blood pressure of 135/85. Pre-hypertension, right? Every doctor in the world would say that's a good blood pressure, right? Okay. But the risk of this person at pre-hypertension dying, not get it, dying from a stroke or a heart attack compared to this person is already increased by 2-fold. Okay? At a normal blood pressure. Okay? And if we had another 20 over 10, and we make it 155 over 95, and a lot of people sit there and they say, oh, you know, with the minority patients, with the black and Hispanic patients, oh, it's so hard to get the blood pressure down, so 155, 160 over 90 is okay. But it's not, because the risk of dying from a stroke or heart attack is increased by 4-fold. Okay? And then by the time we get to a blood pressure, everybody says the degree is high at 175 over 105, their increase of dying is already 8-fold. Okay? All right, so that's why if we have people dying at 135 over 85, then 140 over 90 is not an acceptable cutoff. All right, and we already know from the trophy study that the system is abnormal right here. Right? Okay, so that's why in our practice we don't feel that we're doing good control unless everybody is 130 over 80 or not. And when you look at the charts, most of them are below that. Not just the diabetics. Okay, this is what we want for our regular patients. For our diabetics, we want 125 over 75. Okay, all right. But that's why we're so tight. Now, this is the kicker to this. This is the average weight gap. That's not considering if they're black, if they're female, if they're obese, if they have diabetes, if they have hyperlipidemia. Okay? So if we add, this is a black person, we add 1 to that. So it goes 3, 5, 9-fold. Okay? Okay? So it's so important to control that. Okay? That's why it's so important. Okay? Now, what does that bring us to? So now, apparently, we're not treating the number, right? Because we know that all blood pressure medicines are not equal, right? Because we've already proven from the 2 studies we can bring the blood pressure down and people still die, especially in the VL1 study, okay? Even from the HOPE study, for patients that were diabetic and have renal insufficiency. One group got amlodipine, the other group got ramipril. As a matter of fact, the drop in blood pressure was higher in the amlodipine group, but their mortality rate was higher, okay? So what's going on there? Because it's not just the number, okay? There are other things that's going on. Well, now we know it's controlling endothelial dysfunction, okay? So now what we have to do is change our definition of hypertension. So the Coleman definition of hypertension. The Coleman definition of hypertension. Because apparently we're not treating the number, right? We're not treating the 140 over 90. And we know that we can't use any medicine to do it. So that's why we don't start with a diuretic. We don't start with anything else other than a RAS blocker. Because if we do that, we're not treating the physiology. Okay, so now we're treating endothelial dysfunction. So now, blood pressure under the Coleman definition is not 140 over 90. Okay, it's not. It can't be, right? Right? Because I could give you a water pill and drop the blood pressure, but people still die, right? So that's not what we're treating there. What we're treating is endothelial dysfunction. Now, if we look at the fact, if we look at 91% of patients with CHF, okay, 74% of patients with chronic ischemic heart disease. If we look at 80% of patients with peripheral vascular disease, we look at cerebrovascular aortic aneurysm, about 70% of patients have hypertension. Even cardiac valvular disease, 75% of patients have hypertension. And then we look at patients with stroke. 74% of people with their first stroke and 65% of people with their first MI all have hypertension. Okay, so when we look at that, and we look at that, all of those illnesses and endothelial dysfunction, what we have to do first, if I can get you first to accept the fact that hypertension is the primary, okay? That's the DNA to everything else. If we accept that, and we accept the premise that hypertension is vascular disease, it's not a risk factor, it is vascular disease, because that's why all those other illnesses have hypertension there. So we accept the fact that hypertension is vascular disease. Now we can give the true definition of hypertension. Because we know it's not the number, right? Yeah. We know it's not the number. Okay, we can bring the number down and people still die. So hypertension is not the number. So this is the definition of hypertension. Hypertension is endothelial dysfunction, okay? Manifested micromolecularly by endothelial edema, okay? Thrombus formation, okay, plaque rupture, vasoconstriction, and edema. Then we see macrovascularly with peripheral vascular, cardiovascular, cerebrovascular, renal vascular, retinal vascular disease that's initiated, mediated, maintained by blood pressure, now hypertension, the number by blood pressure of 135 over 85. That's the definition of hypertension. That's what we're treating. Okay? And until we accept that as the definition of hypertension, we're going to treat it wrong. And that's why the step care approach to treating hypertension is obsolete. Okay?